Going back to what you said earlier about low-grade cancers that don't really need treatment, you talked about a 90-year-old man, but can also low-grade cancers happen in younger people?
Yes, they can. So you can think of prostate cancers, we cannot group prostate cancers all in one box. And the analogy is given is we treat the pussycat and the lion in the same way,
yeah.
right? And they're clearly very different. And so if you had a low-grade cancer, so for example Gleason 6, which is one of the things that we use to define what's the biology of this prostate cancer, it may be that patient who might be 50 or 60 could safely be observed, and what we call this is active surveillance. So it doesn't mean that those cancers can't over time change biology, but it means that the patient can be safely monitored carefully with regular checkups, with regular MRIs, with regular biopsies. So if you don't go down the track of not treating the patient with surgery and they're young and you're worried that there's a chance that over time it could change, you still need to monitor those patients and make sure that you have the opportunity to pick things up if they evolve. But that can be useful for patients because if you are 40 and you haven't had children and you want to avoid surgery, so because there's a risk with prostatectomies of both impotence and also incontinence and a whole range of other things that can arise as a consequence. Every treatment has got its own risks and benefits, and so if you can defer that until such time that it's actually required, it's reasonable to do in some patients. But you cannot, that's not necessarily the best approach for somebody who has got a highly aggressive cancer.
Okay. Now moving on into treatment, we can discuss the types of treatments that patients can go through, and then we can go on into castration and how sometimes there's this thing called castration-resistant prostate cancer. So treatment options.
So if somebody has just disease that's localized, so if it's disease that's localized to the prostate and it's low grade, then surveillance is surveillance or careful observation with frequent checks is an option. But if it's a higher grade tumor and it's localized to the prostate, then most physicians will recommend and most urologists will recommend either surgery or radiation is also an option. So often patients will have a discussion with the radiation oncologist and a discussion with the surgeon, and then think about the pros and cons of each and make their own decisions in conjunction with their treating physician. So that's when someone has localized disease. But we know that approximately 40% of men, 40 to 50% of men, unfortunately, will develop metastatic disease, so disease that has spread to bones and elsewhere. In the context of that, then the main treatment has been androgen deprivation, so meaning removing the testosterone within the body, because the testosterone tends to drive this cancer. It's a cancer that's very much addicted to testosterone. So if you can eliminate the testosterone in the body, then essentially you remove one of the key drivers of the cancer, and that is very helpful. The problem with all cancers is they learn how to circumvent whatever you're doing. So you might remove the testosterone production, but over time cancers basically become what we call castrate resistant, meaning that you've castrated the patient in a sense because you've caused them to have very low testosterone levels by some injections that you might give the patient. But despite that, over time, maybe 2 years, maybe 6 years later, the cancer has smartened up to that strategy. And how it's done that is by a variety of different routes. It acquires resistance. Sometimes cancers make their own, what we call paracrine production of testosterone, their own factories. So they basically, within the tumor itself, they have their own production supply of testosterone that feeds the cancer. Sometimes the receptors become mutated, so they become a bit more what we call promiscuous. So they don't have to bind to testosterone, they can bind to other steroids. Sometimes they become amplified, so rather than 2 receptors, you have 10, so they can just basically retrieve the little bits of testosterone lurking around and signal through that. So there's a range of different things that the cancers use to circumvent the castration that you have used. And that condition is called castration resistant. It sort of marks the more aggressive phase of the disease for the patient. We've seen a lot of new drugs being developed in this space. And we see that drugs that still target the androgen signaling are still active in this context of castration resistance. Some of our best drugs, in fact, target the androgen receptor. They block the androgen receptor. So in the context that the cancer might be making more testosterone itself, if you can put a cap on the receptor, then that testosterone can't bind to the receptor. And there are other drugs like abiraterone that actually just remove the block the enzymes that produce testosterone in the body, so diminishing the testosterone levels again. So these have been highly effective. They improve outcome, both progression-free survival and also overall survival for our patients. But again, the cancers will smarten up over time and become resistant to these strategies as well.
So now talking about cancer smartening, that's a very interesting term. Does this happen in all cancers?
Yeah,
or is it something, very...
Pretty much, you know, say when you have, what we call it is adaptation, right? So like all of us, you know, I give my patients an example, right? If you were stuck in traffic and you wanted to go to the market and the traffic jam was really hard, you'd probably park the car and walk if you're 10 minutes away, right? So that's essentially what the cancers do as well. They circumvent, they've got signaling ways to overcome what we're blocking.
And prostate cancer is a patient-by-patient study, as you said, and what about the steps you take for the family? Because like you said, if a grandfather has prostate cancer, there is chances of family members that they could have. There are risks to have prostate cancer. So you always tell your patients, like if you have children or if you have grandchildren, to actively go and ask them to.
So I think you're right. I think we have to take a more comprehensive approach about managing cancers. Overall, I think it's the principles are cancers generally are genetic diseases. If you have a genetic predisposition, you're more prone to getting a cancer. If you've got a very strong family history of cancers, it doesn't necessarily have to be prostate cancer. It could be breast cancer, ovarian cancer, and prostate, pancreas cancer. Then there may be some genetic links that are driving some of that in the family. You know, a good physician would tweak that there's something about this family that's odd that requires, you know, some additional testing or some additional counseling about that. But the risk of prostate cancer for a man who has got other members of the family with prostate cancer actually goes up. So if you don't have a family history of prostate cancer, your risk is lower than if you have a family history with 2 or 3 you know, members of the first degree, second degree with prostate cancer.
And let's talk about the perspective of society, based on your own experience. It's very difficult for men to actually come out and say there's something wrong with me, I think there's something wrong. And do you see that the conversation on prostate cancer should be increased? And what is the level of types of patient that comes in and see you? Are they very reluctant to say there's something wrong with you? Can you please check me out?
So I suppose I'm a medical oncologist, so I'm often not the first port of call. Usually it'll be the GP or it will be a urologist, so somebody who a man is turning up to who complain of some urinary symptoms about. But I think you're right. I think men in overall tend to underplay their symptoms. And I suspect that that's true not just for prostate cancer, but all cancers. You know, there's this sense of, I'm all right, I'm bigger than this, I'm sure I can fix it. So there's this general reluctance, I think, to basically attend to certain things. I think women are generally, as a rule, better and more vocal. And certainly prostate cancer needs a bigger voice.